Okay, good morning or good afternoon, depending on where you are. I have the pleasure this morning of introducing Dr. Robin Goldman. She's an assistant professor in internal medicine and pediatrics at UCSF, so MedPeds trained. And she's currently the assistant director of curriculum and mentorship at UCSF HEAL Initiative and the co-founder of the San Francisco chapter of the Social Medicine Consortium. So for people who are interested in additional training after residency, Dr. Goldman is an excellent resource to talk to you about the HEAL Initiative. She herself completed the HEAL Fellowship with Partners in Health in a rural hospital in Haiti. She also completed an MPH at UC Berkeley, so she has pretty two distinct experiences for the trainees, especially consider reaching out to her if you're considering one of those. Her interests are around social medicine, global health education, and creating systems to empower local providers to care for communities. And I'm going to ask people to put their video on if you feel comfortable doing that, to create more of an intimate, engaged session, if you will. The session is being recorded, and Dr. Goldman does not mind interruption. So if you have a question, you can put it in the chat or come off mute or raise your hand, and I can help monitor the chat for you, Robin, okay? All right,
great.
to you.
All right, so I guess I'll just start, before I start sharing my screen, just to get a sense of who's in the room. Is there anyone who's not part of the PEDS Global Health Pathway here right now? Maybe if you just want to put into chat, if that's the case, and like who you are or what you do.
Yeah, so I think we have a few people. So I can tell you the residents are Sonia, Meron, Kelly, Rebecca, and then Tiffany and Twinkle are part of our administrative support team and experts. So Emily and Efrosini and Megna, if you want to just introduce yourself in the chat really quickly so Robin knows who you are.
Great. Hi, Emily. All right. Okay, well, great. Okay, welcome, Megna. And that's fine. Yeah, people feel free to come and go. Okay, awesome. Thank you all for introducing yourself. I'm mostly going to be using chat or voice as ways to engage you all, but whatever manner is easiest in terms of that. And thanks for the introduction, Teresa. I don't know if I have a ton else to say about myself. I will actually spend the last 5 minutes or so of the talk talking about the HEAL Initiative and giving a little bit of an overview. And I'm also happy to talk more with anyone after this presentation as well. And so I will start by sharing my screen. And then are you guys seeing the actual presentation, or are you seeing my slide, the presenter view?
We see your the slides, not the presenter view.
Okay. I probably should have said this ahead of time, but if people, there's going to be an activity a little bit later in the talk where it is easiest if you have something that you like, a scrap piece of paper and something to write with, and you can grab it at that time. But if you have something nearby, we'll be using that a little bit later. So I wanted to start out, this talk is really about taking a patient in front of you and thinking about how do we analyze the structures and systems that have led to where this patient is. And I think for me, this has been really helpful in sort of bridging clinical to systems and helping both me think about things differently, but also I think sort of process and cope with what can I think be hard work at times. And so I wanted to start out with recognizing the land that we are on here in California, depending on where in the Bay Area you are, where you are on Ramaytush or Ohlone land. And most of my talk is going to be about a case in Haiti, and that's Taino land. Unfortunately, most of that population was decimated with colonization, and land acknowledgement is important to me, and I think for everyone to realize, like, we're all, or most of us, are guests on this land, and really and settlers, and really acknowledging the people who've been here before us and will be here for generations to come. And the objective of this talk is to look at different factors that affect health outcomes, to give you an example of structural analysis based on a patient case, and allow you some time to practice and discuss the uses of structural analysis in your practice. And then I'll end with an overview of the HEAL training program. So I wanted to start out with, if people could just either in voice or briefly in the chat, say what really brought them to global health, or like a one sentence summary of like why you're really interested in this work. And maybe I'll, as people are typing, I'll start talking about myself. You know, I think there are many inequities here in the US, but in college, I had the chance to study abroad in Senegal. And I think the stark differences of that inequity and being in a new environment really brought home to me both the fact that though I was in a country where I was the outsider, I had so much privilege being white and a US citizen, and had so many opportunities that my Senegalese friends didn't have. And I think that really is what started me down this path. And then later, I think for healthcare specifically, realizing how fundamental health is for people to be able to thrive and to achieve and make larger changes in the world. And so that was kind of the beginning of my story. And so what I'm seeing is maternal newborn health and those issues, which I think is, yeah, very near and dear to my heart. Sickle cell disease, where with the burden of disease, the outside of North America is huge. And then I think even disparities here at home. Anyone else? Great. Yeah, how does traditional medicine and traditional knowledge interact with health practices? Okay. For the sake of time, I'm going to keep going, but feel free if you have other thoughts about kind of why you're here and why you've picked this path. Please feel free to write that in. I think from this question, you know, I came to what actually is global health. I think while we talk about global health, it has not necessarily been the same definition over time and may mean slightly different things to different people. And so for the purposes of this talk, I just thought I'd put out a few definitions and really for me, global health is centers around the quest for equity. And this definition is from a paper by Paul Farmer and others. But thinking about global health equity, it's a multidisciplinary approach, which takes into account both large scale all the way to local issues and from social to molecular. And really thinking about how do we take a biosocial approach to what are, without exception, biosocial problems. And I think what follows from that, if we think about equity, what is inequity? This is based on a definition by Kamara Jones for what is racism, but really can be used for any axis of inequity. So whether that's gender bias or colonialism, or many other things where we see disparities and inequities, but it's a system of structuring opportunity and assigning value based on, country of origin or race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and through this really saps the strength of all of society through a waste of human resources. So what both of these definitions really do is bring us from the individual all the way through many layers that surround that individual. And one way that I like to think about it is sort of these layers that a person exists within their interpersonal relationships. These relationships exist within institutions and communities, and all of these are informed by policy. And this is not even just policies today, but policies that go back throughout centuries at this point, and community norms that go back throughout centuries. And so this is called the Socioecological Model, and I think pairs really well with these definitions of realizing that things move from the individual, and the individual can be sort of individual attitudes and beliefs, genetic background, an individual's identity in society, but that exists in so many layers of other things outside of them. And I think for those of us who are direct care clinicians, most of the time you're interacting with an individual, but keeping in mind how many layers affect who this individual person is. And so the socioecological model can be used for many different areas, like education, or things outside of healthcare. And this diagram really focuses in on healthcare and health outcomes. What it shows is, so this is the idea. The idea behind this diagram is what are the things that actually affect the health outcomes of individuals and then populations that are made up of these individuals. And what we see is that there are certain things that maybe we generally put on an individual, whether or not it's fair, such as health behaviors or their access to healthcare. But there are a lot of things surrounding them that really affect their health and health outcomes. So socioeconomic factors, physical environment, and then surrounding all of these things are shaped by our structures and institutions, policies, and race or other parts of identity that have traditionally been associated with various biases in our society. And so these percentages are based on some modeling, and so not to be exact about these numbers, but I think one thing that this highlights for me is that actually the interaction with healthcare is sort of the minority of what what influences people's health outcomes. And I think for me, this is pretty powerful in the sense that while as clinicians, we're delivering direct care, and that is really important in order to really change some health outcomes, we need to think a little bit more broadly. Maybe I'll pause. Any questions on some of that background? I think some of you may have seen all of this before, and for some of you, it may be completely new.
Do you know, Robin, for health behaviors, do you see those as completely independent, or are they more influenced by socioeconomic versus healthcare? Because I think that that's also one of our roles. And as a pediatrician, I know we do a lot of guidance and advice to families about lifestyle, and I'm sure that happens on the adult side as well, yeah. Lifestyle modification. So just wondering how, and maybe they do actually intersect at that health behavior level, just what your thoughts were on that.
Yeah, I mean, I think they do. And yeah, maybe these are sort of false divisions. I think kind of traditionally in public health, you'll see things like smoking or sort of like risk-taking behavior as things that get attributed to health behaviors, but those are totally influenced by your sort of lived environment and socioeconomic factors. And we know that like communities have been structured in ways that may make it more or less likely that people are exposed to different things that lead to health behaviors down the road. So yeah, I don't think that these are totally separate things, and they definitely interact with each other. So I'm going to move us through a case. This is from a community visit that I did early in my time in Haiti. And it's a 2.5-year-old whose mother, says that she just hasn't been doing well, has been really fussy, and is having a lot of diarrhea. And so I was wondering, for those who have thoughts about it, any thoughts on, what's on your differential diagnosis for this presentation?
One of the things I would say would be like a gastroenteritis.
Yeah. And then I'll add, as you look at the child does appear unwell, and you notice that her feet are swollen.
Also malnutrition, or some kind of like a vitamin deficiency or a protein deficiency that's leading to edema and diarrhea.
Yeah, great. Thanks, Sonia. All right. Anything else that people think about?
Toxic ingestions.
Yeah. And so mom tells you this has been going on for weeks now, which I think to sort of help you narrow from like, is this like an acute or chronic thing, pushing you a little more to that chronic. And though you're in the community, fortunately, we did have something we're checking on kids, and so did have a scale, and this child was very underweight, leading to malnutrition as sort of our primary diagnosis for her. And I think, so, you know, when you think about this, the Zami La Santé, or Partners in Health in Haiti, that I was working with, did have a structure for community outreach, and malnutrition, I think, unfortunately, is the top cause of under 5 mortality in Haiti. So a pretty common diagnosis, and that sort of shot up with the chronicity, and this child's weight and physical exam shot up on our differential. And I think, fortunately, malnutrition is pretty treatable, and many organizations have protocols that triage people or triage children to outpatient treatment versus the need for inpatient treatment. The WHO also has guidelines. And so from a clinical standpoint, this was ended up being a pretty straightforward case of getting this child enrolled in a malnutrition program and starting supplementation. I think, you know, things could have stopped there. For me, I think this was a community visit. And I was very early on in my fellowship. And so really just in the place of kind of learning about things, and really just started talking to people about like what was going on and how their lives were. I think where I went with this is really learning and thinking about what gets you to this malnourished child. And so the mom, you know, easily expressed that there was a lot of difficulty getting food for them, and she didn't have a lot of money, and there just wasn't a lot of food around. So I think our typical medical history stops there. And then maybe has anyone, and I don't expect this of people, but has anyone heard of structural competency or done any work on sort of mapping out structures? All right. So I'll put, there's some resources at the end, but the idea of structural competency is really about thinking about what are the systems and structures, as I was talking about, that actually like lead and influence someone's individual health. So, and I think for me, it's actually easiest to start jotting this down on a piece of paper. And so I've put this on a slide, but you start with the most proximate cause. So this idea of difficulty getting food. And then, you know, as I talked more to this mother and members of the community, the complexity of this started to appear. So, they lived in a rural area where people tried to grow crops, both to eat, but also to sell. And so we're really dependent on the crop yield from season to season in terms of both their income and having food. But people told me a few different things. One was that sort of heavy rains and drought had become more common, and the timing of these had not been quite the same as they had been traditionally. And so that had made things pretty hard for people, both losing some crops due to drought, and then also when rains were really heavy, having things get washed out. And so, you know, in my mind, we go to climate change for some of these things. And I think, you know, recently in the news, with her, Haiti has been affected by multiple hurricanes that have really washed out whole towns and parts of the country over the years, which goes even beyond what people in this community were telling me back in 2014. But the other thing that I heard was that when the crop yield was bad, what people did to make money was they would cut down trees to make charcoal, because they were able to sell charcoal to make a little bit of income to then buy food to feed their families. But what they realized is that, every time they cut down trees, that affected both the soil quality and increased the likelihood that there was washout when it did rain. But people felt really stuck in this cycle because they couldn't kind of wait things out, and they didn't have any opportunities for other income. And so then you kind of start thinking about, so there's the environmental and the parts of like just about the soil, but like, why don't people have other opportunities? And so that gets to a whole nother branch of this structural analysis, that there are not a lot of job opportunities in rural Haiti. The access to education is not great. And I could probably do a whole separate thing on that, but while school is free, there are fees for your books, there are fees for uniforms to go to school. Where schools are is hard. So it's really hard for people to get access to education. And then we go into, well, like, what is the funding for that? In Haiti, there's an extra layer that the language that is used in school is French, which is the colonial language, but the language that 95% of the population speak is Haitian Creole. And so really limits, you can't, it is very hard to pop into school as a 7-year-old because you don't speak the language that it is being taught in. And that was very purposefully kept as a language of the elites throughout history. And so that we see going back to racism and this trying to keep sort of the upper class separated from most of the country. So getting really, really far back into this colonial legacy. And then at the same time, just the amount of funding that the government has. I think I was totally surprised to learn when I got to Haiti that Haiti has a history of being the first successful slave revolt, where the slaves revolted and actually got independence from France in the early 1800s. And I think is a great source of pride for the Haitian people. But somehow what happened with that is first, because the many other colonial powers were worried about their slaves revolting, there was an embargo from many countries to Haiti. And then France decided that Haiti, for its independence, should pay back France for all of the lost income it lost from its colony. And that debt was not forgiven until much later than you thought. So I think in the 1980s or 1990s was when France decided to forgive Haiti for its debt, which is totally insane. But really, I kind of just systematically sucked power away from the Haitian people and had so many, so this is something that happened over 200 years ago and still just continued to have effects for centuries. And then to layer onto that, agricultural policies. So even once the embargoes were stopped, different policies in terms of pricing of goods from other countries. And in particular, there was like a flooding of the market of cheap rice, which meant that Haitians who were farming rice, for example, couldn't sell their own rice, as one example. And then you just add government instability to all of this, which has been present throughout history, though is actually in the past, so not as much for this case, but in the past few years has been much more of an issue, and which creates a distrust in government, but also doesn't allow the government to set up structures to help the population. So that is a lot, and I actually could do more than is on this slide, but I think shows, or hopefully shows to you, the complexity of what is a fairly straightforward clinical case, and like how this one kid got here. And this is multiplied by, thousands of children throughout the country. Maybe I'll pause here again and see if there are questions about this.
Is this something you're doing in real time, Robin, when you have the patient in front of you, or is this something where you set time aside, at the end of the week or the end of the busy clinic day to really think about the structural reasons behind the clinical presentation?
Yeah, I have not gotten good at doing this in real time. I think in this scenario, I was on a community visit and I wasn't the primary clinician. So I think I had time to talk to people a little bit more and gather information. I think one thing that it definitely made hit home for me is how, particularly if you're going to a community that is not your own, but I think this has happened to me in the US and in San Francisco and like where I'm from as well. Sort of learning some of the history, and that takes time. So I may have not known about the debt to France even when I was having like these conversations with people in the community. I think they really started talking to me about some of the stuff on the left side of the screen about the soil and kind of income. But the questions around education and language and stuff, that took some time for me to learn. So this I built out over time. I think as you work in a place longer, it becomes quicker to be able to do this. I think an example that has become like much easier for me in the United States is like the history of redlining, right? And that wasn't, I think that's something where like my analysis of neighborhoods and like access to opportunities has become faster, partly just because like I know a place better. And so I can do it a little bit quicker. But generally, yeah, I don't do this necessarily directly in the patient encounter, but sort of start trying to ask some of those questions.
I had a question as well. Sorry, it's really loud over here, but when approaching like a solution, is this another format that you can use? Like, and how many things that solution will affect?
Yeah, yes, I think my argument at the end of this is that this is a way to start working towards solutions. I think for me, this is twofold. The way I process things that are difficult or seem unjust to me is it is helpful for me to have to start processing like why they are the way they are. So I think from just an emotional level or kind of doing the work, it's helpful for me to map some of the stuff out. But I also think that without starting to think of some of these layers, there's no way to figure out a solution if you haven't figured out what are the problems leading to this. And I think also like, what are some of the strengths? And this analysis doesn't do that actually particularly well. But I think as you start mapping out your nodes, you can map out nodes of like, what are the strengths of like these individuals or this community, and where are the things where they've been denied things or they're lacking resources, and like, how do those interplay as you start mapping out solutions?
Yeah, like Marone, I was also thinking about trying to figure out, it seems like a huge undertaking and like trying to tackle this problem in multiple ways. Is there one where if it like, I would assume that it's hard to kind of control government stability. Is
Yeah.
there one that, if it kind of doesn't work, then it would like bring down the whole chain?
Yeah. I mean, I think, so I will at the end of the slide go through one of the ways that Zami Lasante actually worked to address these. So I'm going to save that to the end. I have a few slides on like some of the ways for this particular case. Any other questions about this before I move on?
Yeah, as far as like interventions and kind of prioritizing, like Cheryl was getting at, like one thing kind of might, negate the power of other interventions. Do you have like a framework for looking at this as far as like prioritizing, or a way that you kind of measure these things?
I don't. I think one thing is like, what are you passionate about, and like, what do you feel like you have the interest and potentially the bandwidth to get involved in, and like, what else are other entities in the community that you're in doing? And so like really looking at like, what are the assets and resources around you? And I think for every person, this is going to be different. I think for this example, for example, like you could decide, if you're a person who maybe before going into a healthcare field, really was interested in environmental stuff, that like, maybe this, it's talking about like, how do we get involved in like community planning and like designing spaces, and who are your resources in doing that. But for other people, it may be like a job training program, right? Or something, finding resources for job training programs for parents or something like that. And so I think part of this is like, what do you feel passionate about and interested in? And like, what do you have the bandwidth to do? And where are your other resources? I don't think that anyone expects like one individual alone to start addressing some of these. And, you guys are right. Like the instability of the government of Haiti it's too much for like any one person to start trying to address. But I think, for example, one example is that I worked with someone who worked at the hospital within the sort of like education department, so like training staff. But he was really passionate about like language access in schools, and that was his thing, and really trying to think about like, how do we make schools accessible for the majority of the population. And so it was really spent a fair amount of time working on this idea of having school be in Creole instead of French. And like, that was his thing. And, I talked to him some, and I think if I had decided potentially like that was my area of interest, then I would have kind of used him as a resource. But I think different people have different things that they're passionate about. And I would encourage you to think about like, what are the things that you do feel passionate about, because it will make it easier to try to start working on those areas, and acknowledging that they're going to be, just like, there are people who are interested in different fields within healthcare, and it's good that we all are interested in different things. And for example, like I would be a horrible dermatologist, but I'm glad that there are people who are going to do that, or a surgeon. And I think the same goes for all this stuff, right? There are other people who have different passions and different talents, and you don't have to do all of these things, but really thinking about like what would make you feel good to spend the extra like 5 to 10 minutes on, or, you know, an hour a week.
I think that's really good advice, Robin, because honestly, I see this and understand the complexity of everything that goes into, you know, a malnourished child. Or I don't understand it, but this helps me visualize that. But I see this and I feel overwhelmed. Like, how can I, as a single person, begin to address the, you know, centuries-long racism, colonialism in Haiti? But if you say, you know, actually, why don't you focus on the fact that you can help with, you know, I don't know, local agricultural policies, like that's something that feels more tangible and realistic as an individual to tackle. So I appreciate you breaking it down and giving us something that we can do.
And so one way that this is just a potential framework, and again, this is from the work of Kamara Jones, but ways to think about the different levels that, like, as you build these out, are through, and again, this goes back to your socio-ecological model, but like what's at the institutionalized level, like what is causing differential access to goods and services and opportunities on a societal level, and also what are the norms that we have in society that we need to start questioning. And I think actually the United States as a whole has, in like basically since George Floyd's murder, I think we've started more publicly questioning some of our norms that have led to inaction in the past and taking action. And so that's one example. But I think, you know, there are plenty of norms that deserve questioning in our society. And then on an interpersonal level, sort of like where are you seeing prejudice and discrimination? And this can be unintentional or intentional. And then on the individual level, for patients you're interacting with, what have they internalized, and what have they accepted as these like negative societal messages about their own abilities or worth? And so this is a possible framework that can help you start going through that structural analysis. And before I go into a few of the kind of outcomes of this, or not actually of my analysis, but of someone else's analysis of this, I wanted to give people an opportunity to try to map out something themselves. So pick a patient or a particular problem that you see over and over again, and this can be here in the Bay Area, or if you've had experiences in other places that are coming to mind. And it is probably also easier on a non-PowerPoint slide, but just, you know, starting with the patient or the like one particular issue that you see, and I'd love for everyone to try to start mapping that out, and maybe we'll take till 6 minutes till 9:20. And then I would love to hear people's reflections on that. All right, and if I can bring people back, and that may have felt like a lot of time or not enough time, depending. But I'm wondering if anyone wants to share any reflections they have from doing this exercise, and everything's okay. It can go from overwhelming to to something that feels more constructive. Or if anyone wants to share like what kind of case they picked to map out, I'd be really interested to hear.
I picked a case of a 7-year-old with obesity and hypertension, and kind of mapping out some of the like the family elements, whether it was family history or family, like what the family's buying food wise, or access to physical, like spaces to be physically active at school or at home or in the neighborhood. And I found that like a lot of my lines ended up connecting back to like poverty and racism, and some of these, like the redlining that you were talking about earlier, Robin. And I felt like I needed a lot of the lines intersected in that way. Drawing to that.
Yeah, these diagrams are so messy and like make with
Yeah,
like lots of arrows going back and forth.
Yeah.
Anyone else?
I chose a patient that we saw who had multiple rehospitalizations for an eating disorder at Mission Bay, which is definitely not, I don't think of as a global health problem, but it was kind of the first thing that popped into my mind when you described this exercise, because it's something that we've seen so much this year, and we see patients that like keep coming back, and I felt so like helpless as an actual medical provider, because there's so many bigger issues working against us. And some of those things were like psychosocial stressors, just like from COVID and kids spending time at home and everything, and like not having peer connections and everything that came along with that. And then also just from like a resource standpoint, there was like a lot of these patients were on really long, months-long wait lists to get into some kind of other treatment program or family-based therapy. And that was just like unavailable as a whole. And so they would just come to the hospital because that was kind of the only thing that was available.
And Kelly, to follow up on that, did drawing things out, how did it make you feel about things? The same, better, worse?
I think a little better. Like it's stuff that it's just really, it's frustrating because you just feel like there's like, our job is to kind of like stabilize their heart rates and like give them an NG tube. And it just feels like, and then we send them out into the world and then they come back 2 weeks later because we're not really supporting them. And so I think to just think about our roles as providers kind of outside of, just those clinical expectations, and that we can do things to kind of chip away at the larger picture and advocate for more resources and for, options that will better the lives of our patients outside of the hospital too.
Thank you. Does anyone else want to share?
Yeah, I picked one of my patients that I saw recently in the hospital for an asthma exacerbation. She's only 3 years old. And I think it was a little overwhelming because it was like transport and like hesitation on COVID vaccines, but like going further back to like why African Americans have hesitations on vaccinations and medical intervention. So like, I think if anything, it was a little overwhelming, but also like when you're talking to patients, these are like things that you should be keeping in the back of your mind, and kind of just an appreciation of like how far they had to come to even like make it to this hospitalization, and like still needing to receive the treatment that they do, and like what are some little things that we can do before they get discharged that maybe will chip away at that. And that's maybe giving like a transport card, or but thinking of that about that. Sometimes we're not doing those screens and how important they are. And the climate change, and yeah, a lot of overwhelming issues, but yeah, just a reminder.
Thank you. Well, thank you all for sharing, and I appreciate you doing this exercise. I think we have enough time to potentially watch this 5-minute video before I wrap things up, which I think, so sorry, I'm going to switch screens, but I think is a nice summary. Just 1 second, I'm going to share something. Hold on, sorry, my share screen is not coming up. I think I have to get All right. Please write into chat if you don't hear this, but I think I tried to get this optimized for.
I'm Dr. Kamara Phyllis Jones, past president of the American Public Health Association. You may have heard the saying, an ounce of prevention is worth a pound of cure. When it comes to health and well-being, preserving health is always best. But there's more to the story. Imagine that someone is walking along and whoops, they have just fallen off the cliff of good health. And if that were you, you'd be relieved to find an ambulance at the bottom to speed you on to health care. But what else can we do to protect you? How about a net to catch people? But nets have holes, so some people may still fall through, and the net is likely to rip over time. What else can we do? Clearly, we need to build a fence at the top of the cliff to keep people from falling in the first place. But if a lot of people are near the edge of the cliff, even a really strong fence will not be enough. To keep everyone safe, we need to move all the people away from the edge of the cliff. We do that by addressing the drivers of poor health that go beyond our genes and beyond our personal behaviors. Things like low wages and under-resourced schools and unsafe housing. The environments in which we live, work, and play shape our health. These are the social determinants of health. These things can either propel people toward the cliff's edge or keep them at a safe distance from it. But this cliff analogy is incomplete. We need to also realize that the cliff is really three-dimensional, and then to notice that resources and people are not evenly distributed along this cliff. At some parts of the cliff, the ambulance at the bottom may have a flat tire, or maybe there's no ambulance there at all. Maybe there's no net, nor fence. And usually, at those parts of the cliff, the people are being pushed closer to the edge. These are the differences that lead to health disparities in a population. Differences in the speed and quality of the ambulances represent differences in quality of care. Differences in the presence of ambulances, nets, or fences, these represent differences in access to care. And differences in the distance to the edge of the cliff represent differences in the opportunities and exposures and stressors that make some people and communities sicker than others. We need to ask a lot of questions. Why is the cliff three-dimensional? Why do some parts of the cliff lack ambulances or nets or fences? And why are some people being pushed closer to the edge? It's because our economic system fails to provide an even playing field. It's because racism, which is foundational to our nation's history, is still with us and continues to cause profound harm to us all. And because discrimination against people of color, women, immigrants, the LGBTQ community, poor people, and others holds back our nation's health and well-being. Everyone should have the opportunity to achieve good health. If we try to address the social determinants of health without tackling these bigger systems of structured inequity like racism and sexism, we risk moving some people away from the cliff's edge, but not others. We risk making health disparities worse. Experts at the Urban Institute are exploring how local, state, and national policies have gotten us to this point.
All right. So that, I think, just is a nice overview in video form of some of the stuff that we've been talking about. I think I'll move us back to the end of the presentation. Sorry, we'll just do this again. All right. And so I think this is, actually, you all are pretty positive when you were sharing, but I think what I have felt personally, and I guess Teresa expressed this a little bit in the beginning of the talk, as well as what I've heard from people I work with and other trainees, is as an individual clinician, this can feel really overwhelming, especially given, how busy people are. I think for outpatient providers, you're seeing people every 15 minutes. Inpatient, you may just have a lot of patients to see and then a lot of documentation to do. And so it can feel hard to both spend the time doing this, but also to even bring it up with your patients when you don't have an answer. I think in medicine, a lot of us went into this because we wanted to be able to fix things. And so sometimes it can be really hard to not have to identify issues that we don't have a fix for. And so there's actually been some research on this, and what patients report is that when they're asked about the barriers, outside of direct care that affect their health, they have improved relationships with their healthcare providers, even if the providers can't do anything about it. And I think for me, this was really powerful and sort of changed my own biases about, or my own assumptions about what people wanted from me as a clinician. And then I think the other thing is that, as I mentioned earlier, there's no way to change something if you don't identify it. And so just asking your patient a little bit about their story, I've, in the past couple of years, gotten really into the idea of how, or I think, rediscovered how powerful narrative medicine is, and giving a chance to your patients to voice their stories. And this is easier to do in some clinical situations than others. But I really do feel that stories can help challenge all the implicit biases that exist around our patients, but also can empower them by letting them tell their story, and can give you some of that information that you need to start mapping out some of the things that are influencing their health. And then I think a third thing that we underestimate is how much power you have as a healthcare provider, as someone who is working with patients, to use your voice to make change. You actually have a level of expertise that you may not feel like you do, as particularly for those of you who are residents, but for in society at large, the fact that you have actual experience within the healthcare system and taking care of patients goes a really long way. And I really encourage you all to remember that as you think about, like, what are the things that I feel that I'm seeing. And someone once did a diagram of like, what are the things that break your heart that you see? What are the things that light you up inside? And like, find the intersection of those things and spend time doing that. And you do have, your voice has a lot of power and authority, and use that to help advocate. And so to bring us back to our case, I'm going to talk about one thing that's on the slide, and then some of your questions, I think, it made me think of some other things. When I started learning, particularly about the stuff that was on the left side of the slide, is around agriculture, or just the ability to grow crops and sustainably have a food source in rural Haiti. What I found out is before I had gotten there, other people had recognized this issue, and actually started working with some people who were really interested in agriculture and in like environmental sustainability, and founded a like kind of affiliated, I don't want to quite call partner organization, it's a separate organization, but it's called Zami Agricole. So Zami in Haitian Creole means friend of, and so Partners in Health is Zami La Santé, so friends of health, and Zami Agricole means friends of agriculture. And this organization started working with Partners in Health to try to combat malnutrition by teaching some sustainable agricultural practices to certain communities. And then this slowly grew. And I think one of my favorite things that they do is that they give seeds and goats to families. And what those families do is as their crops grow, they actually will donate seeds back to the organization to sort of continue the chain, and those seeds will then be given to another family or another community. And the same with goats. This only makes sense because there are lots of goats around, but you're given a goat, and then when your goat has baby goats, you actually give back a goat so that can go to another family. But the goats provide a source of income and a source of food for families, and but also help perpetuate themselves so that this can continue down the chain to other families. And I found that model really touching. And so that's how this organization started. And then they have been successful enough and grown enough that they've actually started some training programs around farming and carpentry for people, where they can go and kind of do an apprenticeship for a period of time, and then go back to their communities with what they learned, with the hope that can help both from an agricultural standpoint, growing crops, but they also have started teaching some other trade skills as well, so that people have more access to job opportunities. And this really came about because people identified some of these deeper layers, and then just started talking to people. And none of the clinicians, and actually nobody who works for Partners in Health is actually running or doing these things, but they just started looking around and talking to people who might be interested in doing these things. And then things sort of started snowballing themselves and turned into this really great partner organization. Another example, which is not here in the slide, is within malnutrition, is that this organization, Zami Agricole, as they were teaching people how to farm, started thinking about like, how can we give back to treating malnutrition? And so the Partners in Health negotiated with the people who make plumpy nut to have access to their recipe. And there's a whole thing about capitalism and plumpy nut and patents that I won't get into. But they were able to negotiate access to the recipe, and with Zami Agricole growing nuts, created a factory to make the sort of an equivalent to plumpy nut that they call Nurimamba, to go into, that went to the malnutrition clinic of Zami La Santé, and to go to patients, all basically free of cost to any of the patients. And so it created this really nice synergy of both training and teaching people and giving them skills, as well as actually treating malnutrition, but hopefully addressing some of the underlying causes as well. And so I thought this was a really nice circle of how some of those deeper structures or deeper issues were addressed. So that's the one in this slide. I think a sort of simpler one that came to me as you all were talking. Another thing that Zami La Santé does, and I think they'd love to do this with all patients, but they do particularly for their HIV and TB patients, given that nutrition is so important for disease control. They actually just give people money to buy food. So they get a certain allowance per month to help fight malnutrition among this population. And so I think that, again, is is not creating an organization and doing a training program, but is also like something that, may feel much simpler to an individual health center, an individual clinician, of thinking of like, how can we get, an extra $10 a month for a certain subset of our population, our patient population, so that they can buy food or take the bus or get access to transport in some way. And so that's just another way that I've seen some change in advocacy happen based on the mapping that I showed you all earlier. And so to summarize, when you're thinking about fighting against inequity, the first thing is to really name, like, what is the inequity happening? Like, what is going on? How is it operating? And then what is it that you think you can do, and how can you act to create change? And some additional resources and advice I have, I think, one thing I realized is learning some of the history about where I'm working is so important in understanding your patients and what they're going through. For those of you who haven't been exposed to the Structural Competency Working Group, at structuralcompetency.org has a lot of resources that kind of go through what I did with the mapping. And then the New England Journal has case studies in social medicine that also give other examples of things where a social or structural factor is identified as the cause of someone's illness, and what people did about that. And so those are just a few things to look into that I have found illuminating. I'm going to pause here and see if there are thoughts or questions that people have.
Robin, do you happen to have the link to the New England Journal of Medicine? Or could you send it to me afterwards and I can?
Yeah, I think it is just, yeah, I'll type it in here.
Oh, sorry, no, it's on your screen.
Yeah,
so I
no
can
worries.
Copy and paste it.
Yeah, I can copy and paste it, it's fine. Other thoughts, questions? This is all really hard stuff. So I really want to acknowledge that. But I think it is possible for you all to take steps towards this.
And Maron has a question in the chat. She'd like to hear more about the strength-based approach to structural mapping that you discovered from your interviews.
Yeah, that's a great question, and I think something called asset mapping it is a really nice way to start thinking about what your strengths are. In general, I think our society has a deficit mindset. So it's about like, I don't have enough time, or I don't have enough resources, or this, or I don't have access to this thing. But many times there are strengths both like within your health system, whether that be your clinic or hospital, that you do have access to, and that the community itself, like where your patients are coming from, have strengths that they can use. And so I think, for example, so if I go into my example, I think, people had a really strong knowledge of the land and the issues that they were facing, for example. So, I mean, people realized, for example, that they were making the trade-offs between the quality of the soil and that immediate cash supply that using wood to create charcoal was creating for them. So there was a lot of knowledge there. I think there was also, I think most of our patients want their children to be healthy and do better. And so that motivation is usually an asset in your communities. And then I think, thinking about what are the knowledge or the resources that people do have, as you start to think for solutions, because it's not always about getting more stuff. Sometimes it's about using what you have better than you currently are. I would say the community health worker model that many organizations use is an example of that, right? And so this idea that there are people in the community that have some knowledge, that are eager to get training, that care about their community and want to spend time getting their community healthier, and can work with the health center. So that is an example of an asset, right? Like your asset is for community health workers are the members of the community. And so that would be one example, but to just start thinking about not only what is lacking, but what do these people have, or what exists in the system that I can use differently or use better than I am currently. Hopefully that helps.
Yeah, and as a brief plug too, we do have an entire session based on community health workers. Amelia and Isaac will be presenting that on Monday, August 30th, and they both work with Partners in Health in Malawi. So
Yeah.
that's another model.
Yeah, so that's just one example. I think there are other examples. If Sangeeta is still here, like to take one of her examples from work she's done, there's an example about, you know, transport and using the taxi drivers in a community to transport patients and labs and supplies, and that these taxi drivers were really eager to help people in their community and work that way. So and Sangeeta is, I think, a wealth of knowledge on this. Other questions? I was going to spend 5 minutes talking a little bit about HEAL for those of you who are potentially interested. And then I can also stay on for questions. I want to make sure you guys have a little bit of a break. So I'm going to move to the next slide. So I work for the HEAL initiative. It stands for Health Equity Action and Leadership. It is a postgraduate fellowship program that is really focused on global health equity. And briefly, our mission is to train and transform frontline health professionals through building a community dedicated to serving the underserved as a lifelong choice. And we really believe that people coming together to transform systems, and through the process will also be, we all are transformed. And really the vision for doing this work is that health is achievable for the most vulnerable if we think about equity, justice, and working in solidarity. And the values in the program are really around humility, immersing ourselves in the work, realizing that work is incremental and can be slow, but does grow over time, that this type of equity work is everywhere. It's really important to act in solidarity with the people that you're serving, that responding to structural violence, which is all the stuff that I mapped out, is crucial in this work. And that having a supportive community with the same values as you is also really essential for doing work like this that can be hard at times. We work with 19 organizations, I think across 10 countries. The way, so this is just a map, primarily in Navajo Nation. We also work with one health center in the Central Valley in California, and then internationally, sort of across Mexico, Haiti, multiple sites in Africa, and then in India and Nepal. And the way the program is set up, there are two types of fellows, rotating fellows, which for those of you who are in the PEDS global health track would be what you are. These are US trained healthcare providers who are really interested in global health and health equity work, and want to have an opportunity to work in underserved communities. And then the other half of our fellowship cohort are site fellows, and these are people from a variety of health professions who are already working in our partner organizations, and so are from these communities and know the organizations and the communities decently well, and are kind of committed to working there over the long term. And everyone goes through this training together. The site fellows stay in their job, whereas rotating fellows will have two different placements, but all of the training and a lot of the work at sites may be together. And so as global health training programs go, it is, I think, one of the only, if not the only, bi-directional training program that exists. It's interprofessional and interdisciplinary. You have sites in the US and abroad, and most of the training is focused on social justice and health equity, and we partner with organizations that really take those values seriously and are committed to these organizations over the long term, because we know that for change to happen, it does take time. And And so if you are interested, this is a transnational interprofessional movement, deeply rooted in the experience of local organizations and communities and patients. Really, I think, deeply immersed in the health equity movement in general. And so I am happy to talk to anyone who's interested further details. But and I will stop sharing there. I know it's 5 of, so do they have a break built in, Teresa, or is this the break?
We do have a break built in.
Okay.
And I put some of the links in the chat, and then I don't know if you want to put your email or if you want people to email the HEAL email.
No, they can just email me directly. I think it's the usual UCSF stuff. So robin.goldman@ucsf.edu. If you want to talk more, I'm happy to stay on the line for another 5 minutes if people have questions, either about the content of the talk or about HEAL.
And then I'll also put a link for just a very brief session eval. So before people pop off, if you could it's literally 2 questions. It takes just over a minute to do, but we really appreciate your feedback.
Yeah.
So here's that link.
And thank you all for participating and talking. It makes the session better. And hopefully some of this is a useful framework. And I'll Teresa, I can send you my slides too, if some of the slides are useful.
We'll take the slides and any other resources. I've been collecting the websites you've been sharing so that we can post those as well. But if you have anything else that you would want us to post and share, I'm happy to collect it. And Tammy shared as well another blog link that you can follow if you're interested in the HEAL fellows.
Yeah, and so those are blogs based on their experiences and what people are sitting with as they're actually doing their work at sites.
Okay.
Well, thank you, everyone.
Yeah, thank you, Robin. Really appreciate it. And I wish that if the HEAL fellowship had existed when I was finishing residency, I would have loved to have done that experience. So if you're a trainee, it's something to seriously consider and look into. I think it's an amazing opportunity.
Yeah.
All right. Thank you so much. Yeah, I didn't do it and I'm still biased. So. All right. Thank you, Robin. Really appreciate it.
Thanks everyone. Have a good day.
Bye.
Bye.